CDPH and CMA Virtual Grand Round Series. I'm Dr. Kim Newell-Green, and I'll be your moderator for today's session. The session is entitled, Is Menopause Having a Moment? Updates in Menopause Care. And we know that menopause care and hormone therapy has waxed and waned over many, many years. And given the media coverage recently, it may seem that we're in a bubble of care, but there's a huge gap in physician understanding of recognized perimenopausal and menopausal symptoms and current best practices in menopausal hormone therapy prescribing, alongside the other ways that we can assist women during this time. And many fewer women are actually treated with menopausal hormone therapy than were 3 decades ago. So today we're so grateful to have Dr. Deborah Garrett here to help give context to the hype and review evidence-based practices in the care of perimenopause and menopause. And we're also thrilled, as always, to welcome back Dr. Erica Pond from CDPH for a review of important state health topics. Next slide, please. Just a reminder that you can download today's slide and follow along. Next slide, please. That's how you do it. Next slide, please. I think the next slide is our speaker's disclosures. Next slide, just a reminder that this series is accredited for CME and MOC credit for some specialties. After the webinar, you'll receive a survey where you can attest your attendance. Make sure to complete that so you get your CME certificate emailed to you. And now I'm very pleased to welcome our regular presenter, the Director and State Public Health Officer for California Department of Public Health, Dr. Erica Pond. Thanks, Erica.
Great. Thank you so much, Kim. And it's always a pleasure and honor to be back here again. I will try to be quick, but just give you a few little tidbits about what's happening. There's definitely a lot of interest and a lot of different infectious disease issues happening right now. So let's just get to it. Next slide. So I'm going to cover a little bit about cyclospora, just briefly what's happening with Ebola virus, show you what's happening with our COVID-19 trends this summer, and just a few quick vaccine updates. Next slide. All right, next slide. And in thinking and talking about cyclospora, you cannot, it's been such a hot topic in the media. I'll get to it later, but thankfully we're not really seeing this be a bigger issue in California right now, but just sort of some of the basics. What is it? Cyclosporiasis is a parasite. It can cause watery explosive diarrhea and of course other GI symptoms associated with that. Thankfully, it's a pretty low morbidity disease. Hospitalization is relatively low, usually supportive care. What's also interesting is the incubation period can take up to 2 weeks. So when you're trying to do a public health investigation and understand the source, you're trying to ask people about exposures all the way back to 2 weeks ago. It is not known to be transmitted person to person, thankfully, but it really, in general, is typically a food or water contaminated with human feces, and it is treatable. So trimethoprim sulfa is first line and typically effective. Next slide. Just briefly as well, again, some people can get better without medication, but there can be a relapse effect if untreated, so there can be a remitting and relapsing pattern. Next slide. So what are usually the risk factors or exposures related to cyclosporiasis? Typically, it's international travel. So this parasite is endemic in a lot of tropical and subtropical regions. And as far as domestic acquisition, historically, there have been outbreaks related to imported fresh produce. So everything from raspberries, cilantro, basil, snow peas, iceberg lettuce, which has been the main product implicated in this recent large outbreaks, and some mixed salads that have also been implicated. And of course, people who are prone to more serious illness are those who are often prone to other serious illness with other diseases. So at the extremes of ages, immunocompromised, et cetera. Really importantly, of course, too, is what can people do about that? So making sure people are washing their produce, cooking, especially if there are, immunocompromised or at those extremes, cooking your vegetables or produce, trying to wash things in general is good practices. It doesn't completely get rid of, and even chlorine doesn't impact this particular parasite, but it's helpful just to try to remove the burden of potential contamination. Next slide. Here, I just want to kind of illustrate, this is really largely an outbreak in the Midwest and somewhat the Northeast. It's really happening in the other half of the country, and cases have skyrocketed there. So as far as laboratory confirmed, submitted to the CDC level data, have already surpassed more than 2 times the number of cases reported in 2025, when I think there was only about 4,000 cases. And then there's another over 10,000 cases under investigation, and Michigan has really been bearing the brunt of these diseases. And we have had 2 recent deaths in people with underlying medical conditions. But you can see again, largely the case burden has been in 9 states. And based on very detailed on-the-ground public health work and public health investigation, there's an epidemiological link to iceberg lettuce that was consumed at Taco Bell restaurants. So those were implicated from Taylor Farms, New Mexico, issued a recall in mid-July from their farm location in Mexico, and that's where, based on tracebacks and that epidemiological information, they were able to figure out that particular source. Unfortunately, there are other kind of increases in a lot of these states that are not necessarily linked to that, and they are still working on finding what are the key sources. Next slide. As far as what's happening in California, while we're waiting for that slide to advance, we have just now started to see slightly higher numbers of cases than typical, but not outside sort of the range of variability from year to year. We, of course, think that there's been a lot more testing as there's a lot more awareness, but we do see changes, and we do certainly see increases in the summer as well. Most of the cases in California have been associated with travel to other countries, and maybe 1 or 2 who traveled to these states that had the impacted outbreaks, but we are not seeing. We know that the 1 implicated lettuce, for example, was not distributed in California, and we have not noticed any other links or common sources that seem to be acquired in our state. But we are monitoring this closely. We're monitoring for watery diarrhea and sort of syndromic surveillance, and thankfully, again, we are not concerned that we're seeing outbreak linked to cyclosporiasis here in California. So we really want to make sure, and that you all too are talking to your patients about, it is still very important to eat healthy and eat produce and vegetables, and we're not seeing that increase here in California, and to use common sense practices for having healthy and safe produce and vegetables. Next slide. I'll be moving on to Ebola. Probably go ahead to the next slide. And just this kind of just illustrates again, the current Bundibugyo Ebola virus outbreak is the 2nd largest Ebola outbreak on record, and it just continues to rise much more quickly than any historical outbreaks in the past. It's the largest outbreak in the Democratic Republic of Congo history, and continues to not be close to contain. They're continuing to identify cases that have not been linked to other contexts. This is actually an outdated slide, and I think they're up to 4,000 cases now. Next slide. Also think it's always helpful to show the map of the actually impacted areas. So you can see here in the DRC, the red areas are where there are still confirmed cases, and then the actual provinces, but it is focused in a specific area of the DRC. Uganda actually just declared their outbreak is over. They have not had any new cases since the late June. And then of course there have been 1 French resident and 2 US residents that were confirmed cases that were treated. The 2 US residents were treated in Germany. Next slide. And while I'm talking about this, it's been a challenging area because there's a lot of, not a lot of infrastructure at all, much less health or public health infrastructure, and there's a lot of civil unrest there too. As far as coming into the US, there has been really a zero tolerance from the current federal government on this. So we, of course, have, the risk here is extremely low, and we've not seen any suspected cases here. There have been increasing travel restrictions for, at first, non-US citizens and now US citizens, where there is no entry to the US within 21 days of travel. For US citizens, it's from the DRC. For non-US citizens, it's for any of these 3 states. We'll be watching, actually have not seen, now that Uganda has declared their outbreak over, if they will change that. But We are at the point now where US citizens returning from the DRC, and a lot of these are humanitarian aid workers, either healthcare providers or others who have been there trying to help or doing other work there, are on do not board lists. Several are being quarantined in Kenya in sort of a military type site in tents. We've heard about families trying to get back even though they're over their 21 days of travel, but still on do not board lists and not able to get back. This is pretty unprecedented, not something we've seen historically with other large Ebola outbreaks. And then for US citizens that are coming from Uganda or South Sudan that have been in those countries in the prior 21 days, they have to go through one of 4 airports. And then the CDC has screeners there that then screen them, make sure they have no symptoms then, and have them, they notify the state and local health departments of where their final destination is. So we had been monitoring 100 to 200 persons per day on average of people who had at least passed through. None of them had had high risk exposures, but had at least passed through these countries. But given the recent travel restrictions, the numbers that are coming into the US have dramatically trickled down. Next slide. So just wanted to talk briefly about what we're seeing with COVID increases. Next slide. So we are seeing actually increases in our wastewater surveillance as well as our test positivity, but also helpful to see here that hospitalizations are much lower comparatively compared to those test positivity and wastewater surveillance. And this is, the test positivity is looking like a similar summer peak to last summer. And what you can also see from this graphic is that our summer peak was much higher in 2025 than it was in the winter. And we're starting to see that pattern evolve as well with COVID-19. Next slide. As far as forecasting, et cetera, our team has been looking at both COVID-19 alone. We may see some increases as far as hospitalizations this summer. And then when we look at the overall winter burden in the hospital, it's really going to be, as you can see here, much more likely to be flu. That is the larger burden, a little bit more of a bump in proportionality here in the summer for COVID, and then flu in the winter, but a much lower COVID burden this winter forecasted. Next slide. And then other immunization updates as we prepare for the fall and winter. As far as 26-27 COVID-19 vaccines, the FDA has recently approved the 26-27 COVID-19 vaccines. It will be a monovalent variant vaccine that is JN.1 XFG, which is still the strain that seems to be circulating now. And the manufacturers are on track to have the COVID-19 vaccines available for this upcoming fall and winter. And as I just showed you, summer is really the bigger peak. So if you do have patients or loved ones who have not gotten 25-26 vaccines, it is still effective and highly recommended given this surge we're starting to see for this summer. Next slide. And then that's basically the same message here to go ahead and get it now given our surge, and the recommendations remain the same for COVID-19 vaccines this fall. Next slide. And then quickly for the flu vaccines as a preview, the newest news here is that the mRNA flu vaccine was approved for adults 50 years and over. So that is a new option for, again, 50 years of age and older. And there were a lot of questions about whether this mRNA vaccine now being used for flu would be approved. And we are all grateful that this technology can now be used. It's something that can be producing vaccines much more quickly than the egg-based. And another nice option in our menu. And then there's still the trivalent formulations of strains for this season. We are working on both with CDPH and the West Coast Health Alliance and a lot of the emerging vaccine recommendations to have respiratory immunization recommendations available in the coming weeks, and we'll continue to share those with all of you moving forward. Next slide. And finally, on that note, some of the news yesterday was that there was another executive order doing something similar to what was attempted last January as far as reducing the number of recommended vaccines down to be more similar to Denmark. They're also recommending from the federal government, the president has this executive order saying we should be separating measles, mumps, and rubella into separate single antigen vaccines, which are not manufactured in the United States or really anywhere. They are also looking at potential lawsuits to states like ours that do not have personal belief exemptions in our states. But most importantly for all of you and your patients, we want you to know that California, the West Coast Health Alliance, and many, many, many medical organizations, including the AAP, continue to not change our recommendations because of our AB 144 that passed last fall. All of those vaccines are still required to be covered by insurance here in California. We will have a more updated statement coming out very soon from the West Coast Health Alliance, but we are continuing to be aligned with the AAP and other trusted medical groups around vaccines. And again, the requirements will remain unchanged in California. So I wanted to make sure you all knew that. And I think that is my last update. Yes, thank you all very much, and I will turn it over to the next speaker. Thank you.
Thanks so much, Erica. Erica, before you go, can I ask just one quick question while we have you? Just underlining how grateful we are to have you here for this super up-to-date and very important information. But do you have any knowledge or thoughts about the benefits, risks, pros, cons of the flu mRNA vaccines in terms of, you tell me, cost, safety, et cetera?
I could give you a few tidbits, and I was literally just thinking about this both for this and in general for ourselves and loved ones. So the mRNA vaccine, again, is approved only for 50 and over, and it was only compared to standard dose vaccines. So for the elderly, who of course are at highest risk for serious complications, we don't have as much data. And actually the recombinant vaccine does really well. There's 3 other options as far as high dose, recombinant, and I think adjuvanted is the other. And again, there's not a head-to-head. That trial was really looking at standard dose vaccine. But again, there are a lot of advantages to the technology of being able to not have to grow these sort of viruses in the eggs and be dependent on that. I think it will really help us be more timely with flu vaccine and production. Many of us remember in 2009, it took a lot longer than we hoped to get that pandemic strain produced and out the door. So I think that will really help us. And over time, I'm sure we'll have more data as well to compare mRNA flu vaccine with the different formulations, especially in our populations that we want to protect the most.
Great. Super helpful. Thanks so much, Erica.
Sure. Thank you.
Now I'm thrilled to introduce Dr. Deborah Garrett. Dr. Garrett is a board certified OBGYN who's been practicing for 35 years and does a lot of menopausal care as a certified menopause provider, currently working in Orange County with Kaiser Permanente for a very long time as well. So thanks very much for being here today, Dr. Garrett.
Good afternoon. Thanks, you guys, for all spending your lunchtime with me as we tackle this ambitious project of talking about menopause in 30 slides or less. So today I just want to let you know that my goal is to give you some practical, clinically useful information as all of us find ourselves kind of at the crosshairs of the patients coming in with multiple questions and complaints about the perimenopause and the menopause. I will not be able to go into extreme depth, as you can imagine, on the studies or the nuances, but we'll have time for some questions at the end. Next slide, please. So why does this matter here in California? Oh, here, let me just introduce you. This is going to be the order in which we'll talk. We'll talk about the landscape here in California, some fundamentals, what the evidence tells us, and really equally important, what it doesn't tell us, how we use menopause hormone therapy in practice, and then what are some of the emerging topics, the non-hormonal approaches to some of the symptoms associated with perimenopause and menopause. Next slide. So the landscape here in California. Next slide, please. So here in California, we have to understand this applies to about 6.4 million women. These are how many women we have in California currently between the age of 40 and 65. So really it's about 32% of California's female population, 16% of our total state population. So this is a large cohort of women. It's important we understand this and can actually present this information with accuracy and integrity. Now, Perimenopause, from the Greek peri, meaning around. Perimenopause refers to those years leading up to that final menstrual period. On average, it occurs around age 47, lasts for about 4 years, but can last as long as 10 years. So it is not unusual for some women in their early 40s, maybe even late 30s, to have some perimenopausal symptoms. Now, in contrast, menopause is the cessation of menstruation, so amenorrhea. So on average, around age 52, depending who you listen to, but it's defined clinically, 12 months of no menstrual cycle. However, the symptoms associated with the perimenopause, menopause, they can last up to, in the SWAN study, the study with women across the nation, on average 7.5 years after that final menstrual period, but anywhere between 5 and 10 years. So this is the time frame. And then there's always a small cohort of women, maybe less than 10%, that may have some mild symptoms even for the rest of their lives. Next slide, please. So when we talk about perimenopause and menopause, we are primarily addressing patients that are coming in with symptoms. But it's not just about symptoms. There is an economic impact to helping women feel their best. 49% of working women have indicated that their menopausal symptoms have impacted their performance at work. 76% of women under the age of 50 think that in some way their menopausal symptoms have affected their career. Now, women are primarily at the peak of their career around this age. So this is important information. And a lot of them have not made the correlate. They have not realized that the reason they're not doing their best work may have to do with symptoms that we could help them treat. And then there has been an estimated $1.8 billion in lost work days, loss of productivity. So the take home on this is that this is something really important that we should be talking about, and how we can help women feel their best and live their best lives. Next slide, please. So here in California, there was this perceived lack of attention that we as providers, physicians, were giving to helping women feel their best. I don't think that that was the case, but there was some legislation over the last several years that involved menopause education for us as physicians and our advanced practice providers. And some of these bills had good intentions, but they really weren't well written. Well, after a lot of social media pressure and finally some really productive collaboration between American College of OBGYNs, CMA, and the governor's office, the governor had vowed to put some menopause language and some menopause education in his budget trailer bill. This was just signed on June 29th of this year. Now, the final writing is still being made. We won't know more about this until probably this fall, but some take-home messages. First of all, there will be some options for some CME on menopause care that actually will count twice. So you'll get twice the credit for taking a CME. For us, there is going to be a lot of this burden falling on health plans, but we will really need to understand it. There will be a recommendation for some sort of universal screening of all women between the age of 40 and 65 annually for menopausal symptoms. Women will be able to opt out either for that year or permanently, but it will be there. So this will not just be an OBGYN. This is going to be in primary care. This is going to be in cardiology, psychiatry, endocrinology. So I want to just give you all a heads up so that we can start to think ahead. How can we get our electronic medical records to be able to integrate this information once we know more details? And most importantly, to understand that patients will be coming to you expecting to be asked. So we want to make sure we have the right referral pathways in place if it's something you're not comfortable with. Or that more importantly, we can help educate everyone to at least get the conversation started in an accurate and productive way. Patients should come to us to rely on good information, not Instagram. Next slide, please. So when we think of perimenopause and menopause, I think just, we got to start at the beginning. We got to start with the fundamentals. So let's make sure we understand the definitions, the symptoms, and when hormone testing helps and when it doesn't. Next slide. So perimenopause and menopause is basically a spectrum. It's two discrete phases, but kind of on a long transition, much like puberty. In the perimenopause, again, average age 47, can last as long as 10 years, but on average 4 years. Most commonly, we're going to see unpredictable, irregular vaginal bleeding as a reflection of the ovaries sputtering in their production of the reproductive hormones. Symptoms will start to occur, usually getting worse as you get closer to that final menstrual period. But one thing people forget they have to think about is contraception. Over 75% of pregnancies after age 40 were unintended. That is not the same as unloved, but unintended. So we want to make sure that we keep that in our equation when we're addressing patients' concerns about their symptoms, that we have good contraception on board if that's what a patient wants. And then when we have menopause, that is really a clinical diagnosis, 1 year without a period. But in fact, many of us may not ever know that exact date, and that is okay. But understand that this represents a cessation in significant amounts of estrogen, progesterone, and testosterone production. So follicular exhaustion. And it's when we're menopausal, we can finally say, okay, we're not going to have a pregnancy. There are things that play into this timing, including genetics and lifestyle. For example, smokers go through menopause earlier than non-smokers. Hormone levels are not used in most cases to make this diagnosis or to guide in what dose or what therapy is going to be appropriate. Next slide, please. So the common symptoms that we're going to be hearing, and I know most of you are familiar with them, but in that perimenopause, we talked about irregular bleeding. Again, those ovaries are sputtering, hot flashes, night sweats. A lot of that is from estrogen deprivation, but it's also that fluctuation from highs to lows in the estrogen that will stimulate these symptoms. Sleep disruption, with or without hot flashes, mood changes, brain fog, concentration. I always think of lack of good sleep and hot flashes is almost the gateway symptoms for many of these common things patients complain about. Brain fog, lack of concentration, joint pain. 20% of patients will come into our office with a primary complaint being joint pain. And then, of course, we have the beginnings of vaginal dryness due to the architectural changes that are occurring in the vaginal epithelium. Now, when we get to the menopause and beyond, of course, we still have the hot flashes. We've got the genital urinary symptoms of menopause, meaning a more extended period of time without that estrogen, so that vaginal tissue gets thinner. Even the bladder can be affected. We know that menopause increases cardiovascular risk just because of the lack of estrogen, hyperinflammatory state. Cognitive changes, a lot of those are from not sleeping as well. Weight gain. Okay, central adiposity, skin and hair changes, and certainly we will see sexual dysfunction start to play a role, some of which is related to hormone changes and some of which is related to changes that are occurring as we age. Next slide, please. So when do the hormone levels help me? When do I maybe in practice want to do them? Because I'm sure many of you, like me, have the patient that brings in their little list of all the hormones they want me to draw from their MediSpa, right? Well, as a general rule, hormone levels are not helpful, okay? Because most of the time, this is a clinical diagnosis and those hormone fluctuations are occurring in the perimenopause, whereas one day if the hormone level is normal, but they have horrible symptoms, that doesn't mean I'm not going to help them. And that hormone level tomorrow might be different. The diagnosis is really clinical, not based on a lab finding. But there are some instances where hormone levels may be helpful. And in particular, let's say that someone is amenorrheic because they have a levonorgestrel containing IUD in place, the Mirena IUD. Maybe they're about 50 and they're deciding, I got to take that out. It's time for it to come out. Do I need a new one? We would want to know, is contraception still an issue we need to address? So in order to get an accurate idea of whether the contraception needs to still be addressed, we need to know, is the estrogen persistently low? Is the follicle stimulating hormone persistently high? So 2 levels of both those hormones, 8 weeks apart at least, that are in the menopausal range can give us confidence that we don't need to think about contraception in our future management of the patient's symptoms. What about the patient, less than 1% of those under 40, who is amenorrheic? And we are looking for what used to be called premature ovarian failure, now primary ovarian insufficiency. How do we make that diagnosis? We have at least 3 months of amenorrhea with an elevated FSH on 2 different occasions, ideally at least a couple months apart, where it's above 25. Then we know. And those women have particularly higher risks of bone loss, especially because this is happening very young, and cardiovascular disease risks. What about the patient that comes in on menopause hormone therapy, got great relief for a while, and all of a sudden it's not working for them and their symptoms have all returned? Especially when we're using transdermal therapies. And in this world where generic substitutions are not unusual, it is possible the patient's not absorbing the product well. So in this case, there might be a role for doing hormone levels to see what is their absorption. In the use of testosterone, which we'll touch on at the end, that is a place where hormone monitoring is essential to avoid supraphysiologic dosing, which is associated with a ton of potential adverse, sometimes even permanent side effects. So there are roles for hormone testing, but it is not a universal. And although I know out there it is being done by both professional and non-professional organizations, we really have to be thoughtful and make sure that we are using this for evidence-based medicine. Next slide. So what does the evidence tell us? And I'm going to, again, take very broad strokes here and keep it as brief as I can, but just to share with all of you what we know, because there was a lot of media representation of what was actually being said. But I think it's important for all of us to have at least a cursory idea of what the data is that we have, as much as what the data is that we don't have. So next slide, please. So menopause today, I don't know about you, but I feel like I'm on the battlefront, okay? On one side, I've got social media with viral, personal, immediate, repetitive information, which often gets mistaken because of its repetitive nature as being fact. We have anecdotal stories. We have products that are being touted by the manufacturer with just enough education to make them sound like they're really got good data, cherry picking of data. And so then on the other side, we've got evidence-based medicine, which is nuanced, cautious, evolving, and some of which we just don't have all the answers. We need to individualize the benefits for each individual in terms of their own medical history. The formulation that we give, the route of delivery, it matters. The timing of initiation of hormones, it matters. And what other risk factors do we have to keep in mind? And by the way, you got to do all that in like less than 20 minutes. It's a challenge, right? So let's just see where we're at. Next slide, please. So where have we been? There was a lot of studies indicating how hormone therapy, starting in the late 40s, all the way through, was the key for longevity, key for keeping women feeling good. As a matter of fact, when the original WHI, Women's Health Initiative, was started, it was because there was a lot of observational data that it looked like estrogen had cardiovascular protection, and it was the key to longevity. Okay. As a matter of fact, even Wyeth, the maker of the drugs that were used in that study, had in their advertisements that the conjugated equine estrogen they were using, it was going to make women happy and husbands happy. So this big trial, randomized control trial, sponsored by the NIH in combination with Wyeth, used the most popular products that were on the market at the time. And that was conjugated equine estrogen, as natural as it comes from a pregnant horse's urine, but containing multiple different estrogens, some of which work differently at different tissues, and medroxyprogesterone, a very common progestogen. And if you had a uterus, you only got the conjugated equine estrogen. And if you didn't have a uterus, it was the combination, and each of those arms had a placebo against it. And this was designed primarily as a preventive trial for cardiovascular disease. Okay, multiple studies have emerged out of this data because it was such a big study, but remember, it was not designed for some of those. And as a result, when you start to extrapolate, you may not have the power to make in the study to make those accusations. So in 1998, enrollment was complete. And by 2002, the one set of arms with the estrogen, the conjugated equine estrogen, and the medroxyprogesterone arm was stopped because it met the threshold for VTE, okay, and it had increased risk for breast cancer. sense. We'll talk about what the media interpreted. But the other arm, the conjugated equine estrogen arm alone, persisted for another 2 years. And there's a lot of important findings in there that weren't talked about. But as a result of them stopping the trial in 2003, we got a black box warning on all estrogen containing products. No one had any, they didn't distinguish between a transdermal estrogen versus an oral estrogen versus a pure estradiol product versus a conjugated equine estrogen. Local, systemic, none of that played a role. The FDA class labeling put that black box warning on every product. And of course, women were in fear and everyone stopped their hormone therapy. Everyone was afraid they were going to drop dead of breast cancer. Now, what they didn't share was that the breast cancer risk may have been slightly increased, maybe 0.4%, but the women who had breast cancer had a 40% better outcome, less mortality. Okay, we'll talk about that in just a minute. So then in 2020, when we did a look back, because those women were followed, what we actually found was that women on hormone therapy had no all-cause increased risk for mortality, that it probably was actually quite safe. And then the other big thing down the spectrum of where we've been with data is what recently happened in 2025, where a couple meta-analysis got released, taking that black box warning off. Why? Well, for vaginal estrogen, it was a big win. We knew that topical local vaginal estrogen did not increase the risk for breast cancer or reoccurrence of breast cancer in breast cancer patients. And finally, these women were going to be able to restore their normal vaginal epithelium and not suffer. That was good. There are some other changes that we'll talk about with that black box warning removal, but currently there's only a black box warning for protection against uterine cancer in those that have a uterus. They cannot use unopposed estrogen. Okay, now this black box warning may exist on some current products. I just want to point that out because this is kind of a rolling change. Not all products have converted over. Next slide, please. So what did the study actually show in summary versus what did the media tell us it showed? Okay, first of all, the design of the study was really a primary prevention trial, right? But what the public heard is, oh, it's going to test and see if menopause hormone therapy relieves symptoms. And yes, we knew it did relieve symptoms. Okay, but that's not what it was designed for. The population was actually on average 63, over 10 years older than when we start menopause hormone therapy today. Okay, but what the public heard was all women starting hormone therapy, regardless of how old they were or how many years since the final menstrual period. That's not how we prescribe menopause hormone therapy today. We consider this. The formulations. This was only relative to this oral formulation of conjugated equine estrogen and medroxyprogesterone. Well, in this world, modern hormone therapy, that is actually not the most popular way we administer hormone therapy. But what the media and what people heard was it applies to all hormone therapy. Okay. Breast cancer risk. Hormones cause breast cancer. That's what everyone heard. But the reality, as I said, was that the estrogen and progesterone may have had about a 0.4% increased risk for breast cancer, but the mortality from disease in those women was much lower. And what no one picked up on in the media was that in the estrogen only arm, which continued another 2 years, those women without the medroxyprogesterone had a lower risk for breast cancer. And the other fact, just kind of interesting just to think about, is that so many people stopped estrogen therapy. I don't know, for those like we were practicing, the insurance company stopped covering, right? You would think that if it really caused breast cancer, that we would have seen a drop in the prevalence of breast cancer, but that's not what we saw. And then in terms of cardiovascular disease, which is what the study was designed, it did not show any protection necessarily in cardiovascular disease, but it didn't show any worsening. And this is the timing hypothesis, because we took the women that were only 50 to 59 in the study, which I think was around 10% of the population. And those women actually tended to suggest that they had less cardiovascular disease. But definitely in the older women, especially in that first year after starting, they had an increased incidence of cardiovascular disease. And this was the beginning of what is called the timing hypothesis. But public heard hormones cause heart attack. Not true. So again, all-cause mortality, when it was looked back in 2020 in the JAMA article, there was no difference when comparing women on hormone therapy versus placebo. Next slide. Now, a couple other trials I just want to go through quickly just to make sure you've heard of them and just tell where they sit in our historical. Okay, and remember, WHI was going on, finished enrollment in 1998. So in 1995, we have the PEPI trial, which is really what confirmed unopposed estrogen in a woman with a uterus can cause endometrial hyperplasia and endometrial carcinoma. You've got a uterus, you've got to use a progestogen to protect the endometrial lining. The Ester trial, what it was really looking at was transdermal estrogen, very similar to what we use now, combined with micronized oral progesterone. And it was associated with a lower VTE risk in comparison to oral products. That's a big deal. And that is really kind of one of the cornerstones of modern hormone therapy today. The KEEPS trial just confirmed that low dose, even using the same product that was in the WHI, but at a lower dose. So a low dose oral conjugated equine estrogen with versus a transdermal kind of mid to low range estradiol, that both were really safe and did not seem to increase the incidence of atherosclerosis. And they were looking at the carotid, which may not be the best way to look at risk for atherosclerotic disease. We know that now, but it was a measurement, a secondary measure that was being looked at in many of these trials for evidence of cardiovascular disease risk. The ELITE trial was really testing this theory, this whole timing theory, which we alluded to in the WHI. In other words, if we start menopause hormone therapy in those first 6 years, and now maybe we say 10 years since the final menstrual period, that we actually don't seem to see that increased risk in atherosclerosis progression. That's a good thing, right? And then in the meta-analysis, the one that there was 2 of them that released in 2025, both showing the safety of topical vaginal estradiol in terms of use in breast cancer patients, not increasing the reoccurrence of breast cancer, and how it can really help decrease UTIs, improve sexual function in these women. So the formulation, the route of delivery, the timing, and the selection of the patient, that's all important when we consider menopause hormone therapy today. Next slide. So the single most important reframe that since the WHI is that menopause hormone therapy is designed to be used for symptoms affecting someone's quality of life, ideally under age 60 or in the first 10 years of menopause. And I say that because I think that age 60 is a little bit gray, certainly under 65. When we start getting beyond that, okay, the risk potentially for cardiovascular events may be going up. We used to say that we should be using hormone therapy for the lowest dose for the shortest period of time, but that mantra is no longer what we use. Right now, it is more along the lines of the right patient, the right route, the right dose for as long as symptoms. And we think that their benefits are outweighing the risks. Next slide, please. So in practice, these are the common things that I get asked all the time. And I wanted to just share with you where we're at with cardiovascular risk, breast cancer risk, bone health, cognition, and the genital urinary symptoms of menopause and the use of menopause hormone therapy. Next slide. So what's the leading killer in women? Cardiovascular disease, right? 1 in 3 to 5 of us, depending who you read, dies of cardiovascular events. And what seems to be ignored in all this is what we've known a long time. I mean, let's look at how we optimize other lifestyle factors. Now, the menopause transition in and of itself can be a kind of environment that can set us up for cardiovascular disease. Low estrogen, hyperinflammatory. Many of us find that we are gaining weight in the middle. We are finding that we are not as active. So here's the risk factors that we know of that are universal, and I think that all of you could name them: obesity, diabetes, hypertension, poor sleep, chronic stress, family history, autoimmune disease. But here's what it was not given quite enough attention. There are gender-specific risk factors for women. In taking your history, please ask about, did you have a history of preeclampsia or pregnancy-induced hypertension, gestational diabetes, depression, menopause in and of itself, especially early menopause, PCOS, or what's called PMOS at this time, preterm birth. These are also increased risk factors for cardiovascular disease. Next slide. So a thorough history, as we know, is an important part of care. And the cornerstone for decreasing cardiovascular disease really falls on the essential 8 from the American Heart Association, or at least the 6 pillars, knowing that smoking cessation is one of the biggest factors to decrease the risk for cardiovascular disease. Healthy heart diet, okay, whether that be Mediterranean or a DASH diet, getting physical activity, weight management, blood pressure control, looking at our new guidelines, trying to get everybody under 130/80, improving sleep, stress management, optimizing glucose levels, and optimizing cholesterol. So if we could get these things under control, there is thought to be about a 70% reduction in cardiovascular disease. That's a big deal. Hormone therapy is not a primary or secondary prevention strategy for cardiovascular disease. We know that. The studies don't show that it protects the heart. I hear that talked about. We don't have the studies. As a matter of fact, the studies we have are mostly on oral estradiol or conjugated equine estrogen. We don't really have a ton of data on transdermal estradiol. And we know that transdermal estradiol is pretty lipid neutral. So keep that in mind. Now, some of the scary statistics that are out there, that in 2019, only 22% of primary care physicians and 42% of cardiologists felt comfortable talking about cardiovascular disease in women. I'm hoping after today's lecture that's changed, and that at least you can start the conversation and get the essential 8 on board. As many of you are aware, we have new recommendations that have come out in the Prevent ASCVD recommendations. Some of these include things like, are we doing an annual lipid panel? Are we looking at least once in a lifetime doing a lipoprotein a for genetic predispositions to atherosclerotic disease? Selectively, are we looking at those with hyperlipidemia about apolipoprotein B, telling us a little bit about their increased propensity for potential for atherosclerotic burden? Are we selectively using coronary calcium scans to maybe coerce patients to take that statin they didn't want to take? We know that statins as a first line for cardiovascular disease are far more effective than even the small increases in cardiovascular health that we saw in the young women that used menopause hormone therapy. So if we really want to make a dent in decreasing cardiovascular disease in women, I think we really need to look more carefully, take a better history, and really try to optimize the things such as cholesterol and all of the essential 8 by the American Heart Association. Next slide, please. So what about when breast cancer gets brought up? And so again, when we talk about breast cancer, a couple key points. The WHI showed us that it is probably not the estrogen we should be so fearful of. It's actually the progestogen. And how that works is the progestogen is what is going to be there at that receptor for the breast cancer stimulation. Estrogen might make more progesterone receptors, but it's the progestogen, because the women that didn't take the Provera, the medroxyprogesterone, had a lower risk for breast cancer. So keep that in mind. Micronized oral progesterone, the data suggests, it is not definitive, that it is more breast cancer friendly. So rather than use the synthetic progestogen, such as Provera, we have universally rather switched over to micronized oral progesterone in practice to protect that uterine lining. It is a bit weaker. And so there's some nuances in practice, which I'm happy to answer questions afterwards about, but it is a bit weaker. But it is our preferred progestin protection for the uterine lining. Vaginal estrogen does not require a progestin to be used. So it can safely be used without adding a progestogen for these patients. And it has not been shown in the studies to increase the risk of a recurrence or the occurrence of a breast cancer. And then let's just keep in mind that there are many factors related to breast cancer that are probably equal in terms of increased risk for breast cancer to modern hormone therapy, such as alcohol, daily consumption, and obesity. These things probably carry greater risk for breast cancer than any kind of hormone therapy for symptom management. Next slide. When we talk about breast cancer, we do have to talk about screening. And as many of you are aware, there are updated guidelines. We're going to now start at 40, which is better aligned with where American College of OBGYNs has been. Every 1 to 2 years in your 40s, depending on your risk factor profile, and then up until at least age 70, 75, but then to be selective. It doesn't mean stop at 75. And as a general rule in practice, most of us believe that if someone has a 5-year survival rate thought to be very good, definitely continue screening, okay? Because we know that breast cancer mortality can be directly related to the time of diagnosis. So early diagnosis, much better prognosis. Now, if you have the time to do a tire acoustic model, I know some of the radiology teams will do it for you. Yes, but bottom line is if someone has a greater than a 20% lifetime risk of breast cancer, they may need mammograms alternating at 6-month intervals with MRIs. But the gold standard for breast cancer screening remains digital mammography. Now, tomosynthesis, which is out there and is thought to be potentially a little bit more sensitive, may decrease callback rates. And it is recommended for those with heterogeneously or extremely dense breasts, but still the gold standard is digital mammography. And here in Orange County, one of the common things I'm dealing with is they don't want the radiation. Remember, the exposure with a digital mammogram is about equivalent to that we get in flying from here to Florida. So often by just sharing that perspective, many women realize, oh, okay, I'll go get it. Next slide, please. Osteoporosis. All right, bone health, super important. And the one chronic condition that we know estrogen helps us with. Estrogen protects us against bone loss. It protects against bone fracture. So in the WHI, 24% lower hip fracture. And that's no small potatoes. Because remember that there is up to a 20% mortality after someone breaks a hip. And it is the leading reason a woman will go from an independent to a dependent lifestyle. So screening for bone health is important. For those women, for example, who choose not to or don't need to use hormone therapy, we still need to have the conversation. We all start losing our bone mass in our 30s. So first-line therapies are optimizing calcium intake, ideally in whole foods, but no more than 500 on a supplement at a given time, 1,200 milligrams a day for those over 50, and everyone would benefit from 1,000 international units of vitamin D. I don't need to do vitamin D levels on everyone, okay? Most women would benefit from that. Estrogen can be helpful, and although all of us are recommended to have a bone density by age 65, there are times when we do it earlier. As a matter of fact, it is sometimes used in our stratification profile on who might benefit from hormone therapy. In other countries, it is actually done earlier as part of that decision-making process. So in those that had chronic steroid use, very petite, earlier menopause, smokers, these are people we may want to screen a little bit earlier to be more proactive in getting their lifestyle on board for good bone health, and then to see if they have symptoms, they may benefit from hormone therapy in particular. We all know we have other options that can help prevent excessive bone loss. Today's talk is on menopause, but there are other options out there. Next slide, please. And then what can we say about dementia, brain health? Not much. Contrary to what the social media will tell you, there is no good data yet that hormone therapy helps prevent dementia. There were some observational trials, but then when it got expanded into larger studies, it did not prove to be true. As a matter of fact, there was one study that showed that when it was initiated over age 65, there was a worsening of dementia. So for those patients, and I know it's scary, but for those patients that come to us saying, I want to start hormone therapy because I want to prevent dementia, there's no data for that. That is not an indication. Next slide. All right, so we're going to wrap it up here so we can get to some other questions. Vaginal estrogen, I think we've touched on quite a bit. Safe for almost everyone. Would love to see it over the counter someday. There are vaginal lubricants and moisturizers that can be helped. Next slide, please. And then just to touch on some non-emerging things that are out there. Many of you are familiar with the next slide, neurokinin drugs that have just been released. Can't pronounce either of them well. Fezolinetate, which is known as Veosa, works on those in the hypothalamus, at the thermoregulatory centers, helps. And then the newest one released in October and FDA approved, Elizinitate, which is Linkette. It also works at 2 of the receptors, helping with sleep. These are great non-hormonal options for women that have symptoms that either don't want to or cannot take hormone therapy, particularly my breast cancer patients. Next slide, please. And in terms of sexual health, we can skip over this, Kim, if you'd like. But I want to leave time if anyone has any significant questions. Just know that testosterone therapy has an indication for hypoactive sexual desire disorder, which is only one part of libido. And so for those interested, we have to just be careful. We have to monitor testosterone levels and remember that women only require 1/10 the dose that a man needs.
I guess maybe I'll just stop you there. I know I want to have you on for another hour, Dr. Garrett. Thank you for this, but just specifically when I think about testosterone, and then some other questions, some others of our audience were asking about things like bioidentical HRT, compounded hormones that I think we're hearing about a lot of times in various parts of our healthcare delivery system. Testosterone also seems to have a huge amount of interest among people. How do you think about those sorts of things in general and specifically?
So a couple things. First of all, bioidentical, a marketing term we've adopted just because it became so universally used. It just implies that it's chemically similar to what our bodies make, but all of these are made in the lab. No one's taking estrogen out of our young daughters and giving it to us, right? So bioidentical products, they're commonly used in modern hormone therapy. I don't think any of us should be worried about that. And micronized oral progesterone is one of those. And I've already alluded to it's probably improved lipid safety and breast cancer safety. And estradiol is the workhorse of the 3 estrogens that we make. So that is something that is part of our modern therapy. Transdermal therapy has estradiol. I think all of us should be familiar with that. When it comes to testosterone, I think we have to understand that not everyone needs testosterone. And libido is several different things. We have pain associated with it, from dryness. We have, can I even mount an orgasm? Am I even interested? That's what hypoactive sexual desire disorder is, when it causes distress because you aren't even interested. Testosterone has data to prove that it has a role in improving that. But we must keep it at the physiologic range. And these pellets and injections, which are being given, in my opinion, willy-nilly by non-professionals in many settings, I think they're setting up women for potential risks, permanent risks, clitoromegaly, voice changes, not to mention the unsightly things, acne, hair loss where you want to keep it, hair growth where you don't want it. So, and I can't take the pellet out. I can't. So we do testosterone therapy in my practice, but we monitor it. And that's what it requires to be done safely. And we can't ignore the fact that it potentially, at least orally, it caused increased hepatotoxicity, gynecomastia. And there isn't an FDA approved product for women yet. Hopefully soon.
Well, thank you so much. We've had a lot of interest, more questions that we can't answer today, but I really appreciate your time, Dr. Garrett, and of course, Dr. Pan, as always. I really want to thank you both. Just a reminder, don't forget to do what you need to do to get your CME and maintenance of certification. Our next virtual grand rounds will be October 6th. Mark your calendars now. We'll have more information about that in the coming weeks. Have a great day, everyone.
Thank you, everyone.
Thank you.